without further ado, good evening, everyone. This is the first in a series of webinars organized by the Continuous Medical Education section of the Kenya Ear, Nose and Throat Society. And we are proud that this day has finally come when we basically are obeying the laws of nature as of now. Our presenter today is Dr. Mbira Gikonyo. Dr. Mbira Gikonyo is a senior ENT consultant who is in private practice and also a lecturer at the Kenyatta University. Our topic for today is on the biology of COVID-19, its clinical presentation and its management. We hope at the end of this session that we'll have gained useful insight, especially from an otolaryngological aspect of COVID-19. Now, without further ado, just a few housekeeping sessions, please. If you want to ask any question, please ask in the either raise your hand up at the end of the presentation. There's a raise hand button at the bottom, or you can also put your question in the chat section. So without further ado, welcome, Sir Dr. Mbira Gikonyo. Thank you very much.
Thank you very much for the invitation. I'm happy to be with you this evening to discuss this topic of COVID-19. As you're all aware, COVID-19 is the single most significant socioeconomic event in the history of the modern world. Its impact around the world will have lasting effects for many, many years to come. And it's more than a disease, it's more than a global pandemic. It's a real big challenge and an issue that is engaging governments and societies all around the world. Dr. Chungo, you can help me mute some of the extra mics so that we are able to continue. Now, you know, we have what they call a novel coronavirus, SARS-CoV-2, which is causing the global pandemic. It was first seen in December last year, actually 1st of December. And as December went on, there was a cluster of patients with pneumonia linked to a seafood wholesale market in Wuhan City in Hubei province of China. From there, previously unknown beta coronavirus was discovered, and this was shown to be what was actually causing the peculiar pneumonia that was seen. A signature publication dated 20th of February 2020 in the New England Journal of Medicine actually was able to outline and demonstrate exactly the experiments he did to prove that was the virus. And I'd encourage anybody who's got time to look at that because it shows exactly how they came to that conclusion. Now we need to go back to the basics and ask ourselves, what is a coronavirus? And a coronavirus, there are a large family of viruses that are known to cause illnesses, from the common cold to more severe diseases, such as what we call the Middle Eastern respiratory syndrome, and also the severe acute respiratory syndrome. The anomaly is zoonosis. Most of the cases, they actually come from bats, which then go on to an animal known as a pangolin or civets, onto humans. For human purposes, there are actually 7 coronaviruses that affect humans. Previously, there were about 4, now we have up to 7. Some of them are not very significant, like what I've got, the first one in the 229E, the NL63, OC43, and the HKU1. Those are not very, very significant. They cause the equivalent of common colds. But there was one known as MERS-CoV, which is a beta coronavirus that causes Middle Eastern respiratory syndrome, which was seen in Saudi Arabia in 2012. So that particular one was particularly significant. It was transmitted from camels. From there, back in 2002, there was a more severe one known as SARS-CoV, another beta coronavirus that caused severe acute respiratory syndrome. And this did cause waves around the world. People were worried it would become a pandemic, but it fizzled out. But the SARS-CoV-2, which is very closely related with the SARS-CoV, is what has created the current challenge. And I've got a link there where you can read a bit more about the physiology and biology of it and exactly the amino acids that make it up. Now, there's a lot of controversy concerning where did this SARS-CoV-2 actually come from. So controversial has the matter become that China has now banned all research into this and now restricts any research that has to do with where it originated from, and Chinese scientists are no longer allowed to publish without the government reviewing their publications because it's so controversial now. The Wuhan wet markets were believed to be where the first patients got it from, and that it was jumped from bats or to pangolins or to civets, cats. However, nearby there's a Wuhan Institute of Virology, which is China's only biological safety level 4 biolaboratory, only a few miles away from the seafood market, and also Wuhan Center for Disease Prevention and Control. And of course, right now, America promotes the theory that actually this came in from a leakage in the laboratory. The Chinese, of course, deny this. However, way back even in 2015, 2014, the head of the research project in the Wuhan Institute of Virology, she's known as Shi Shenglin, had published many, many studies related to bat coronaviruses and was able to show horseshoe bats collected from caves there did have SARS viruses, and that these SARS, like coronaviruses, could interact with the human angiotensin converting enzyme receptors. Americans are aware of this research and in fact financed part of it, but the research was very controversial because it was felt if this leaked out, then there are going to be huge problems similar to what we are currently experiencing. Last year also, there's an Mbira known as Fort Detrick in Maryland, USA, and there they have a laboratory, bioweapons laboratory research center, which has been there since the 1940s. And last year, there was some leakage of some viruses from there. In fact, the American CDC ordered it closed. So some people claim it leaked from the Wuhan Institute of Virology, others claim it leaked from the US, and others that it came naturally. So this is a controversial part of it all. But moving on away from that, of course, you're talking about animals. Some of you may want to know what the pangolin looks like. That's what it looks like. It's about a foot long, up to 3 feet long. And then, of course, the civet cat looks like a cat. It's found in some parts of Africa, but it is mainly found in Asian countries, and the Chinese eat it as a delicacy. Now let us move on to pathophysiology, which are a number of issues we need to discuss. One of them is that, of course, now the infections have become very, very many. We have up to 4.5 billion people infected. However, you must realize, and I think all of you are aware, that the amount of testing being done, even in Western Europe, even in America, is limited. And the real number is closer to 20 million, especially once you start doing serology. If you compare the serological tests in New York City compared to the PCR tests, you'll find that the serology tests show the infection is up to 5 times more than what is being seen right now. Therefore, though we have 4.5 million infections, the real number may be up to 20 million. The number of people who are dead are believed to be 300,000. Again, the real number may be much higher. It is believed, for example, that China hid a lot of information concerning the number of people who died, and that many of the deaths are not properly recorded as being due to COVID. But for now, it is 300,000. Then the beauty of the illness is that the people who are asymptomatic and those who have mild cases are up to 98%. So most people getting sick or being infected do not actually get sick. Or if they get sick, it is very, very mild. Those who get severely sick or critically ill and require to be admitted are only about 2% worldwide. True mortality is estimated at below 0.1%. This 0.1% you'll see is a much lower figure than what is normally reported. And the reason for that is that because many more people have been exposed than the ones currently being tested. So there's some studies which have looked into all of that. And when they take that into account, they say the true mortality is around 0.1% or slightly less. We all are aware that this is an airborne infection picked up from the air we breathe, droplets from other persons when they talk, when they sneeze or cough. But a droplet can actually go up to 4 feet, up to 4 meters from the person shedding the virus, which is why we are taking the various precautions which are being taken. The virus also can be picked up from surfaces such as doorknobs, rails, clothes, utensils, which are touched by COVID-19 patients. This means that even when you go shopping, the shopping bags, the very products you pick up, their surfaces can be contaminated if they are touched by somebody who has that particular virus. At the moment, because we don't have very many patients with it, this may not be a significant event, but eventually, if the situation got out of hand, that becomes significant. The incubation period is about 4 to 5 days before viral shedding begins. Symptoms come between the 7th and the 10th day. Presentation of the hospital is around the 8th day, between the 8th and the 10th day for most cases. However, what is interesting to note is that viral shedding of the virus by the affected person can be up to 20 days for those who recover. So it is not the traditional 2 weeks, up to 20 days on average. For those who end up critically ill or even dying, they continue shedding the virus until they die. So those who are very sick remain very, very contagious, which is why one has to be very cautious around them. Still on pathophysiology, all viruses are basically the same. They enter the body and do only one thing, which is to make copies of themselves. The rest is a battle between your immune system and the virus. The immune system usually wins, but occasionally it loses by overreacting or underreacting. In SARS-CoV-2, it enters through the mucous membranes of the eye, the nose, and the mouth. It is basically a respiratory virus, just like SARS and MERS were. There are 2 lines of defense which are available to everybody. The first line is what we call the innate immune response. It is non-specific, physical, chemical, and cellular immune response. It includes the physical barriers of the mucous membrane of the skin, the various proteins and molecules found in tissues, as well as some of the white blood cells that attack non-specifically invading organisms. This immune response is general, non-specific, and kicks in especially early and quickly in children, which is why they are less affected. The other immune system is the adaptive immune response. This one is specific to the pathogen presented, and it is known as acquired immunity or specific immunity that attacks the pathogen. But it may also over-attack and end up harming the body or causing excessive reaction, as we will see. Now, there's something very, very interesting, which we should remember from our microbiology days. Basically, viruses attack people over a 2-week period. Almost all viruses, actually, it is basically a 2-week attack period. Here, I've got a diagram which shows what happens with a different virus, the measles virus. I don't know how well you can see, but when the measles virus begins to attack, it begins on the first day, and then slowly the number of the viral load or amount of virus particles keep on multiplying. They keep on multiplying, and then it rises up with the viral number growing rapidly until almost the 8th or 9th day, just like the current COVID. That is when you get the respiratory illness. In the case of measles, you end up with complex spots. Meanwhile, now you're actually shedding the virus from the 8th day up to the 16th day. Virus shedding is taking place. Over and above that, we then have the disease, which is manifest in the case of measles. From there, then the viral load begins to go down. What makes a viral load go down? It's because at this particular time, we end up with the antibodies kicking in. So what this diagram illustrates is what happens in every viral infection. There are a few exceptions, but by and large, this is what happens. And this is the same thing that we see in the COVID-19. Same kind of pattern, same kind of days, same kind of activity, because the virus is merely making copies of itself. Now, the most important receptor in the case of COVID-19 is the angiotensin converting enzyme. There's a carbopeptidase receptor, which is what enables the SARS-CoV-2 to actually be able to gain access into the body. Now, this receptor is widely expressed, is very, very much expressed in cardiopulmonary tissues, in hematopoietic cells, including monocytes and macrophages, and this is very, very important in terms of the pathophysiology. A key feature of COVID-19 infection is low lymphocyte count, which is correlated with the severity. Then the lymphopenia is a biomarker of poor prognosis in COVID-19. It's not specific because it's seen in other illnesses, but it is one of the biomarkers which we can use. From there, we move on to the single most important part of the pathophysiology, which I believe most of you have heard about, the cytokine storm. This is a common term, and we'll go into some details here so that all of us are on the same page. When it comes to the cytokine storm, we first of all need to ask ourselves, what is a cytokine? A cytokine is a substance such as an interferon, an interleukin, or growth factors, which is secreted by cells of the immune system and has an effect on other cells. Cytokines are very small proteins involved in cell signaling, immunomodulating agents. So they make sure that the immune system behaves in a particular manner. Now, the cytokine release syndrome is an acute systemic inflammatory syndrome, which is characterized by fever and multiple organ dysfunction, which is caused by a large, rapid release of cytokines into the blood from the immune cells. So if a lot of cytokines are released, you end up with a systemic, meaning the whole body, inflammatory syndrome with fever and multiple organ dysfunction. And this is when the patients end up presenting in hospital. Now, the cytokine release syndrome is a major cause of the morbidity. In other words, those cytokines, and this cytokine storm is what causes many of the problems you actually see in these patients. So you can see the problem is not the virus, it is the body's reaction to the virus that creates problems for those who get sick. Elevated serum concentrations of cytokine interleukin 6, which you might remember, IL-6, and other inflammatory cytokines are the hallmarks. They are the most commonly involved in this cytokine release syndrome. And once we see elevated IL-6, you end up with respiratory failure, we end up with acute respiratory distress syndrome, and we end up with adverse clinical outcomes. Therefore, that interleukin 6 is very, very important as a marker of what actually happens to the patients. From there, we end up with elevated C-reactive protein, CRP, because this is driven by the IL-6. And therefore, the elevated C-reactive protein is also an important biomarker in COVID-19. Still on the cytokine storm, the cytokine release syndrome results in high circulating IL-6, as you've talked about. Now, this IL-6 concentration, they cause a complex to form on the cell surfaces of almost all the cells. But this is especially much more so in endothelial cells of the blood vessels. And this is what leads to most of the problems we end up having or experiences. So we end up with what they call a cytokine storm, which is basically secretion of vascular endothelial growth factor. Vascular endothelial growth factor with a monocyte chemoattractant protein with interleukin 8 and additional interleukin 6. So when this takes place, we end up with the vascular permeability increasing. You end up with the leakage even of blood and intravascular fluid into the rest of the interstitium, precipitating a pathophysiology. You end up with the patients getting hypotensive, and we end up with pulmonary dysfunction with acute respiratory distress syndrome, because our blood is leaking into the interstitium, it's leaking into the lungs, and you end up with the severe pneumonia that we end up seeing. Now, this is a hyper-inflammatory syndrome, and we end up with low blood counts because the blood is actually leaving the intravascular space, and you eventually end up with multiple organ failure. So you find they end up with liver failure, they end up with kidney failure, they end up with heart failure, and they end up with brain disorders and confusion and mental health issues, because now the brain can no longer function in the normal manner. In addition to elevated serum cytokines, high concentrations of ferritin, which I think we've discussed another time, result from what we call the macrophage activation syndrome, which is now the source of the ferritin, because the macrophage activation syndrome normally has a role in reticuloendothelial ion signaling. So the moment now that blood begins to leak into the tissues, then the macrophage activation syndrome comes in, and you end up with excess ferritin, and this can also be measured in these patients, especially the ones with severe COVID. And then we end up with the serum ferritin is raised, high interleukin-6 is raised, and this is at the height of the cytokine storm. Now, this is a diagram which I think will be a bit difficult to see from where you are, but basically shows the coronavirus there affecting dendritic cells, affecting macrophages, and affecting monocytes. And then as a result of that, the mediator for all this is interleukin-6. From there, it goes through two different pathways. There's a cis pathway to the lymphocytes and a trans signaling pathway to the endothelial cells. And then from there, you end up with a cytokine release disorder, blood vessels, permeability increasing, monocytes are recruited, neutrophils are recruited, and then you end up with the vascular leakage. In the liver, you end up with high CRP, serum amyloid. So various factors come in, and then you end up with that hyper-inflammatory process, which is now what eventually will lead to some of the complications that we end up seeing in these patients. As you can see, the complication is an immune system disorder as opposed to the viral disorder. And that is why at this point, even if you give antivirals, it doesn't matter, because the illness is no longer coming from the virus. It is coming from an overreaction of the immune system. And at this point, it is an immune disorder. Let us now go on. Having discussed all of that, you can now understand why the COVID is now recognized as a multi-systemic disease, very different from what it was originally when we were first told about it. Today, doctors are seeing a range of syndromes in COVID patients. They see the traditional fever, the pneumonia, and the acute respiratory distress syndrome, which is what is known from the very beginning. But we also have dyspnea. But the interesting thing about this dyspnea is that some of these patients can have hypoxia of even 60%, 50%, but they're active. They can be talking to their phones, they can be walking. But if you put a pulse oximeter, you'll find they're actually hypoxic, but they're not recruiting the extra muscles of respiration, because it is not a respiratory hypoxia. It's an hypoxia being caused by the leakage of blood into the interstitium, and that blood is no longer available for oxygenation. So when they begin to deteriorate, they deteriorate very, very, very fast. And one of the things that every doctor now should have in their office is a pulse oximeter. There are some very, very cheap ones which use batteries. And if you get a suspicious patient, just take their oxygen levels, and you'll be surprised that this may actually easily give you a diagnosis. Kidney failure is now very, very common, mainly due to the exact cytokine reaction. Heart inflammation, they have myocarditis, they have, all manner of, cardiac issues around the endothelium of the blood vessels. And this, can compromise their cardiac function. Then, of course, we've already talked about it. They have hyper and even hypoimmune complications. Hyper with the cytokine, system activated, and hypo, you end up with low CD8 counts. And all this can contribute to the complications that are seen in these patients. From there, we move on and we end up with multi-system organ failure, because when the kidneys are affected, they cannot get enough oxygenation. The heart is also affected, the lungs are affected, the brain is affected. So systems begin to shut down, which is what leads to the death in some of these patients. Nowadays, the strange thing is, originally they told us this is a disease of the elderly. In Italy, it used to affect only the very old. You had to be 80 or 79 years old in Italy to get it. But by the time you got to New York, people in their 20s and 30s were getting it. And now still in New York, young children, they have got more than 100 with what they call a Kawasaki-like disease, which appears like a toxic shock syndrome. in young children, even 1 year old, 4 year old, 5 year olds. And they're ending up with what we call a pediatric multi-system inflammatory syndrome with fever, inflammation, hypovolemic shock. And so now the COVID is not merely a disease of the elderly, it is also a disease of children. But the main thing to remember in all this is the endothelial cells. This is where the pathophysiology is taking place. Because the endothelial cells are damaged by the inflammatory process, we end up with thrombosis. We end up with blood leaking out. We end up with the hypertension. And then you end up with strokes in much younger patients. You find a 30-year-old, a 20-year-old who was previously healthy has a stroke because of the emboli are forming due to endothelial damage. And even pulmonary embolism occurs, which can lead to death. And in these patients, you find blood clots of all sizes throughout the body. It can be in an artery. It can be in the brain. So this is one of the syndromes which is really disturbing doctors dealing with these patients at the moment. So now, top to bottom, from neurological disorders up to something they call COVID toes, from the young to the old, the whole body is now affected by COVID in the severely ill patients. So the manifestation is now better understood and is now much more than what was previously thought. Many, many doctors are saying that it's a very confusing picture and it's going to take time to understand. And part of the reason is that it keeps on changing. So we just have to keep on trying to learn so that we can be able to understand it. But it's what in news they call a developing story. It keeps on changing and you have sometimes to change as it changes. Now we'll go back to the issue of transmission because this is very, very important in terms of prevention. And everybody knows that it occurs when droplets of water containing the virus are expelled by an infected person in a cough or a sneeze or talking or simply exhaling out. These aerosols, when inhaled, they can reach the eyes of another person and the virus is transmitted. So what basically it means is what we have been talking about, that merely talking to somebody who is infected can give you the disease. If you don't have a mask, if they cough, it's even worse. If they sneeze, it is even worse. So this is what causes it to be so infective and to be transmitted so easily. Generally, of course, also when this virus is on surfaces and you touch those surfaces, then of course you can transfer them to the eyes, to the nose, or to the mouth. Again, that is very, very well known. What I want to mention here is what we call the attack rate or transmissibility, how rapidly the disease spreads. Normally, by something we call the reproductive number, or R0 or R0. This represents the average number of people which one single infected person will transmit. According to WHO, the number is between 1.4 to 2.5, meaning basically one person can transmit it to 2 people. Other studies have shown that one person can even transmit it to 4 people, others about 3 people. Now, if an outbreak of an illness has a reproductive number below 1, that illness will disappear. It will not be a pandemic. It will not be an epidemic. But if the number rises to 2 and above, then you end up with the kind of situation that we currently have in the world, whereby the disease spreads considerably. So this is where the social distancing measures come in, because they stop the transmission of the disease from occurring too rapidly. Now, just mention briefly on presentation. Already we've mentioned some of it in the pathophysiology. We know, all of us, fever, dry cough, tiredness are the most common symptoms. Less common ones are body aches, body pains, sore throat, diarrhea, conjunctivitis, headache, loss of taste or smell, which is very important in ENT, and then a skin rash or discoloration of fingers or toes, what they call the COVID toes. So those are less common symptoms. The serious one are, of course, when you cannot breathe, breathing difficulties or shortness of breath, chest pain or pressure, or when somebody has a loss of speech or movement, meaning even the brain is getting affected. Those are serious ones which require admission. For us in ENT, the loss of smell is extremely important. And there's a study by Yan et al., which says that up to 68%, which is a very high number, more than 2/3, of COVID-19 positive patients report olfactory impairment. So you should always inquire from your patients whether they can still smell well or whether they've had a change. And up to 71% also report taste impairment. So this is a very important finding. They did a comparative study in the control group who are negative for SARS. The loss of smell was only found in 17% of the patients. And therefore, this is a significant finding, and the results are published in the International Forum of Allergy and Rhinology. And therefore, this is one of the things that we need to take into account, especially as we talk to the patients and discuss with them. The most important thing, which of course all of us are aware, is that the vast majority of these patients are asymptomatic, more than 80%. They will never know they had it unless you do tests on them. And when serology becomes available, then it will be very interesting, because even us as ENTs, maybe some of us already got this thing and recovered without knowing. And therefore it will be interesting to see the serological results, and that you could be among the 80% who get the illness and never get sick at all from it. Then from there, I see somebody has raised a hand. Is the moderator with us? Or do I continue?
Continue, Dr.
Yes.
We'll take the questions at the end of your presentation.
Sawa. Thank you very much. Then I'll just continue. Now, this is a slide from the Ministry of Health in Kenya. They normally give out these slides every day when they're giving their reports. And here again, you can look at the distribution of the cases. And you see the symptomatic, like on this day, which is about earlier this week, I think on the 11th or 12th, you see that this is the 11th of May, 3 days ago, Monday. You see that the symptomatic patients were only 22%, and the asymptomatic were 77%. So that ratio of 20 to 80 is maintained, which is quite remarkable, especially because in Kenya, they tend to target the sick and their contacts. So despite that, you see that is very much maintained. And then again, I'm not going into details of this, but the same stories. The fevers are the most common, coughs are there, difficulty breathing, same symptomatology. So the disease manifests largely the same around the world in terms of what you expect to see in the patients. Now let's come, briefly to diagnosis, because this is one of the challenges with the COVID-19. And the definitive diagnosis is a test which is known as real-time reverse transcriptase polymerase chain reaction test. This is a gold standard and involves taking normally a throat or nasal swab from the patients. Whereas it's a gold standard in that it measures for you whether somebody has got the virus or not, it's a very complex test which involves trying to get genetic material of the SARS-CoV-2 virus. And the challenges involve, of course, the patient is uncomfortable, the health worker is uncomfortable, the process is complex with many components. So in fact, they say it is notoriously complex, and you need highly trained technicians using very, very specialized equipment. And even one of the makers of this equipment says that the slightest DNA contamination disrupts the results. So if the person taking it, sneezes, the doctor or the nurse, before they put it into where they're supposed to put it into the test tube, into the reagents, then of course you can end up contaminating the result. So it's a complex test, requires several hours. In most countries, you can't get the results the same day, you get it the following day. Other places, even many days later. So it's a good test, but it's complex and it is expensive. In Kenya, it runs for about 10,000 shillings per test, but the government normally does it for free. Then this is the other important slide. There's a study that was done in April this year, published in the Journal of American Medical Association, and it shows in each of these, swabs, what do you expect? If you went for the bronchoalveolar lavage fluid, which of course you cannot do unless a patient is admitted and very, very sick, you get positive rates up to 93% of cases. Fibrobronchoscope, brush biopsy, 46%. Sputum, 72%. Nasal swabs, which is what we normally do, and people in Mombasa are joking that wanaweka hiyo pamba mpaka inafika kwa ubongo. There you can get 63%, so it's a good test. Pharyngeal swabs through the mouth, 32%. Feces, 29%. So you should be very wary of public toilets. Huh? Blood, 1%. Urine, 0. So the important thing for us to note is nasal swabs will detect up to 2/3 of cases. Pharyngeal swabs, only 1/3 of cases. So it means you always have about a 30% false negative rate, meaning the patient may be COVID, the patient may be shedding viruses, but you're going to miss it in at least 30% of the patients that you test. Therefore, if you test somebody and they're negative, it doesn't mean they're negative. There could be a false negative result. So it's always good to know that this is not an absolute thing. In China, they had huge problems. There were some patients they had, including the first doctor who raised an alarm for the pandemic. And they were sure he had it. The CT scans showed he had it. Everything about him was manifest COVID. But they had to test him up to 6 times to actually be able to get a positive result. So that is a challenge with this particular test. Then now we move to other tests, which are the serological tests. Serological tests, all of us know about them because we saw a lot of them during the AIDS pandemic and we are familiar with them. So I'll not talk much about them. They exist with accuracies above 98%, some almost 100%. But they are not very, very popular with WHO, even with governments. They're able to detect IgG and IgM. However, they become positive only on the 7th and the 8th day. And 7th and 8th day, by that time the patient is sick, by that time the patient has been shedding viruses. So, maybe that's why governments don't like them. But, serological tests are very, very useful because they measure the blood, they're more accurate, there are fewer, false negatives and false positives, and you can end up knowing what is the actual prevalence in the population. And that is what we really ought to try and start doing in Africa. Now, as I said, the 7th to 8th day is when the patient is symptomatic, and it's obvious the person is sick. For those who actually get sick, they shed viruses, and that's when they get admitted to hospital. It's very, very cheap. It costs about 100 bob to do these tests, and they're actually available. Maybe because it's so cheap, maybe that's why African governments don't like it that much. But they're available. Hopefully, they'll come to the country. Cambria had offered to start doing them, and even Kavi, Kenya. The guys deal with HIV in Kenya, Professor Anzaya. But somehow people are not very keen to start that. Now, serological tests, I'm not going into details because all of you know them. They can neutralize. Their neutralization tests, which can indicate if the patient has active functional antibodies inhibiting viral growth. Then they what we call immunofluorescent assay tests, where the pathogen can display a fluorescent signal when the antibodies react to the virus proteins. Then there's what we've done so much about in HIV, ELISA tests, rapid serological tests, providing a readout of the antigen-antibody interactions. And then the old famous Western blot is again back in town. It used to be there in HIV, and is used in the laboratory settings to detect the presence of a protein of interest by the emission of a colored or fluorescent reporter marker when an active antibody interacts. So these are serological tests which we are familiar with because of HIV, and they are similar, they work in the same way, and they're cheap to do, and hopefully they'll be available in Africa and in the country in the near future. Again, I'm not going into many details, but again, all of you know that when you get infected, you end up with the IgM coming up first, followed by IgG during the first infection. And then if you try and get a second infection, they come up very, very quickly because of memory cells, and they're able to neutralize the infection. And normally, use so far plasma, but even in America, they have some where they can actually use saliva, and they're increasingly, available. But in Africa, we are still relying largely on the donations from China, and therefore, so far, these have not yet come. Now we shall go to CT scans briefly, mainly because, as I mentioned, the polymerase chain reaction test is very, very complicated. It often gives you up to 30% false negative. So the Chinese, who are ahead of the rest of the world in this disease, because it began there, used to use chest CT scans. And to them, they claimed chest CT scans, once you know what to look for, had a higher sensitivity of COVID-19, even compared to the polymerase chain reaction. And they did tests and published studies. For example, you can see in this particular one, they said that positive rates of the polymerase chain reaction assay, 59%. Well, chest CT scans could show you up to 88%. Therefore, the chest CT scan was more sensitive in the diagnosis of patients with COVID-19. And they said when they had a patient who already had tested positive for COVID with the PCR, and they compared it with the CT findings, measurements, they were able to actually confirm with the CT scan up to 97% of cases. Therefore, it's a very, very sensitive kind of way of looking at it. And they did an analysis, and their conclusion was that serial, PCR assays and CT scans, in the PCR assays, they got 60%, CT scans up to 93%, and therefore they felt that the CT scans were a very, very good way to try and diagnose COVID-19 with high sensitivity. In Africa and Western world, they don't use CT scans much. In Africa, they tell us that 1, CT scans are expensive, 2, they're not available, 3, they are often not available where the COVID patient actually is, and the patient has to be moved from the COVID ward to the CT scan machine, and that this exposes health workers to risks. And therefore, the radiology departments in most hospitals don't like that. And therefore, nobody, in Africa and even many parts of the world uses a CT scan in the manner that they used it in China for diagnostic purposes. Here it's, rarely do they bother nowadays do it. Yeah. Then to continue, let's now come to the question of management. We've looked at the pathophysiology, we've looked at the presentation, management. Management, I'll be very, very brief because we don't need to go into management because it's not an ENT management. I'll just mention some of the ideas around management and what they actually do. But if ever one day people want management, we can always invite an internal medicine person to come and tell us about the management. But I'll just mention what we need to know as ENT people. Of course, prevention is the best treatment and the only cure, if you call it that. If you can prevent the illness, you do very, very well. Of course, if you get it and your immune system takes care of you, that's also a very, very good, outcome. But that's unpredictable. So healthy immune systems mean that less than 2% of patients end up with severe to critical disease. So most of the patients, the COVID is not a big threat. They'll get maybe a cold, they may have a fever, they may feel unwell for a few days, but they're okay. In places like New York City, where I have family who live there, and even if they would get sick, and they'll just be told, stay at home, take acetaminophen, like Panadol, just hang in there. And within 2 weeks, one recovers. So many, many people, they just need supportive, support and some analgesics, and they'll be fine. It's not a big issue for many people. Now, for those who end up, the 2% who end up sick, they're all manner of, treatment given, mainly supportive. Antipyretics, of course, are very important because they have fevers. Anti-inflammatories, they have pains in the joints, they have all manner of pains, and of course, it's an inflammatory kind of condition. IV fluids, is there. Then, of course, there's experimental medication: chloroquine, hydroxychloroquine, AZT, steroids, virals, interleukin-6 antagonists. So all these are being given with all sorts of results. However, most patients, even the very, very sick, recover. And in almost all the tests, in almost all the studies that are ongoing, because they're ongoing in Kenya, they're ongoing in Europe, they're ongoing in China, These experimental therapies do not make any difference. You can give chloroquine, you can give azithromycin, you can give steroids, you can give antivirals, you can give it doesn't make a difference. When you do a nice proper parallel study, some they even abandon because some of those other medications are actually not working. But of course, it's still early days. Maybe the dosage is wrong. The situation could change. Antibiotics are, of course, prescribed for pneumonia. If you have pneumonia, the bacteria are going to follow the virus. So if somebody has proper pneumonia in the ward, they give them, the bacterial antihistamines, antibiotics. Oxygen therapy, of course, is indicated when saturating. Intubation rarely works. In many places, more than 80% of intubated patients die. But of course, they give one-off stories, like if you put the patient to lie on their chest instead of lying on their back, that alone can end up with a much better result, even more than intubating the patient. Unfortunately, for these patients who are very, very severe cases of COVID and those who decompensate end up with ICU, they end up with very many complications. There are many neurological sequelae, including Mbira syndrome, encephalitis. In the chest, some recover, but they end up with pulmonary fibrosis. Therefore, their lung function never recovers. Many of them end up with chronic renal disease and require dialysis. Others end up with chronic fatigue syndrome, and they can barely walk 100 meters without exhaustion. But many others end up with mental and psychological syndromes. And some of these are consistent with something known as post-ICU syndrome. And that can take up to a year to recover from. So it's very, very important, if possible, to avoid this illness, because the complications for those who get very sick can be debilitating and even career ending, depending on what line of work you actually are in. Some people ask, why don't antiretrovirals work? Because this is a virus. Why are these medicines not working? And the answer is very simple. Like there's one drug, remdesivir, being promoted by Gilead. Gilead is a very famous, very huge American company that makes many of the antiretrovirals the US government buys to send to Africa. They're very well connected with America, and they've been pushing their medicine very, very much. And studies done in China and even in Europe, they show there's no real benefit, from it. But recently, they've been publishing stories in the media claiming that if you take this medication, instead of taking 14 days to recover in hospital, you're going to take 12 days. In other words, it'll make you recover slightly faster. And it's already been bought by the US government in millions of doses and being distributed even in America. But it's basically a political, connection. But the reason why they don't work is because antivirals work poorly in acute disease because of their mechanism of action and the host response. For example, this particular drug inhibits what we call RNA-dependent RNA polymerase, and therefore it stops viral replication. However, the problem is by the time a patient has symptoms, by the time a patient is sick, the virus is already at a peak level. The viral load is already at maximum. So even if you try and stop the virus from replicating, it's too late. The COVID, state is already there. Cytokine storm is already there. The inflammatory processes in the endothelia are already there. And therefore, the antivirus drug, even if it stops viral replication, at that point, it is no longer a viral disease. It's an immune disease. It's a body which has overreacted, and therefore trying to stop the virus is too late. The damage is already done. So that's what we're saying. Cytokine storm has already set in. Damage is done, and therefore the antivirals at that point are of no value. So unless you gave it before somebody was sick, and people are not going to take medicine when they're not sick, that's why they don't work. Then the other what we call interleukin-6 antagonists. I'm not going into details about this, but we said the interleukin-6 is a principal, cytokine that is involved in these inflammatory processes. They're trying them, but generally poor results so far, no benefit. Of course, people who make them are still pushing them, but the objective science says it's not working. Finally, we come towards the question of vaccines. Of course, everybody is excited about vaccines. And with vaccines, there are a number of ways that they actually make vaccines. One of them is what we call, protein subunit, from the virus itself. Another one is what they call RNA, because this is retrovirus. So the RNA, they take that to make the vaccine. Other method is what we call non-replicating recombinant vector. All these are various ways of making the vaccine. As of the 15th of April, which is last month, a month ago, they had 86 candidates, vaccine candidates. Now they've got more than 120 vaccine candidates. So people are working very, very, very hard. The reason they work so hard is you can make a fortune in billions of dollars, in fact, in almost trillions of dollars if you make a vaccine for this illness. So they claim using RNA offers advantages in terms of speed, scalability, if it is successful. However, the timelines remain 12 to 18 months, which is a long time. It would mean that maybe the earliest you get a vaccine maybe December next year. By the time that vaccine is given to the Americans and the Europeans and the Chinese, and it comes to Africa, maybe 3 or 4 years. So you can't count on the vaccine. You have to stay with prevention, because prevention works much better than the treatments and than the vaccine. Towards the end now, let's ask ourselves, who are the doctors who get infected with COVID? Because we are doctors and we are worried. People, the GPs or emergency room doctors get affected in 40% of cases, mainly because this is where the patient presents. At the time they call you, they've already exposed themselves in many cases. Internal medicine, of course, are the guys managing them, 6%. Dentistry, 5%. Cardiology, 5%. Ophthalmology, our friends, 4%. ENTs, we had 4%. Respiratory doctors, 3%. Psychiatry, 3%, others, 3%. So we're not too badly off in terms of those who end up with a problem. But of course, we have to be cautious. And, towards the end, there's a strategy by what is known as Africa's CDC, Center for Disease Control based in Addis Ababa. They have a huge budget of $430 million. But they have 3 pillars. And one of the pillars is preventing transmission. This is the most important in terms of what needs to be done. The other one is preventing deaths, of course, when people are sick, to make sure they don't die. And then, of course, preventing social harm. Because as you said, the biggest problem with the COVID is not the people getting sick or the people dying. It's the effects of the economy. People cannot go to work, people cannot socialize. And that is really what is creating the biggest problem. And therefore, we now end and we can take questions and hear, what people may wish to ask. Thank you very much.
Thank you very much, Dr. Mbira Gikonyo. Thank you very much, Dr. Mbira Gikonyo. Thank you so much for your extensive knowledge of virology. We really appreciate it as Kents. You are a really good asset to us in terms of at least we are able to have someone who is vouching for us in the COVID-19 background. So thank you very much. It was a privilege listening to you, Dr.
Thank you very much.
Yes, so thank you, Madam. Again, we welcome everybody. Thank you. We have 71 participants, which is really an excellent record, Dr. Everyone wanted to listen to you.
Thank you.
We have 71 participants, our colleagues. I'm sure they have gained a lot. They've gained a lot of insight. Welcome everybody once again. My name is Dr. Chungo. I'm the current CME convener for Kenya ENT Society. And now we will go to questions. I can see some hands up and I have several questions that our colleagues have written. Unfortunately, there's no Zoom T. Please, if anyone is technologically savvy, please form an app called Zoom Tea so that we can have tea after a Zoom webinar. I think everyone would love that. Thank you very much. So we have a question from Dr. Mujahideen, Senior Consultant. Dr. I'll just unmute you. Kindly go ahead.
Yeah, hi, Dr. How are you?
Very fine.
Thank you very much, Mbira. That was, I think, quite a detailed look into the general pathophysiology. I wanted to thank you and Kent for that, but I had a comment which is mainly to do with the particular impact on not on all medical personnel, but especially us as ENTs.
Yes.
Now, about 2 months back, when the whole issue started. I mean, both the national and the international narrative was so much doomsday-like that all of us, the vast majority of us, went into our shells. Most of us closed our clinics or only did emergencies. And I think the main, because this topic was pathophysiology, mainly I want to lean on that. I think the main pathophysiological question that we have is, why has Kenya not seen the disasters that have occurred in other countries? And I'm thanking God that we did not. But what are the possibilities? Now, I don't want to make this question is not a lecture, but allow me one paragraph, Bwana Chairman.
Sure,
the issue of, is it, hello, yeah, is it to do with our population demographics? Are we very young? Is it something to do with BCG? All these theories have been propagated. Is it something to do with malaria and chloroquine? Is it something to do with our altitude, our temperatures, our humidity? Actually, nobody knows. Now, 2 months down the line, in fact, nothing much has changed. But today, I saw the traffic in Nairobi. I think people are almost deciding that, look, we are going to go back. Now, are we quoting disaster? I don't think know the pathology. I don't think we have understood which part of the curve we as Kenyans are in. And we as ENT, being the most at risk professionals, are we really jumping from the frying pan into the fire? It's more of a feeling rather than a question. Maybe other people can contribute. Thank you so much. Over.
Thank you so much, Dr. Dean, for the question. Dr. Mbira Gikonyo, would you like to?
Yeah, I'll just comment. The question Dr. Dean has raised is a very, very important question. And we have what we call a COVID school in Nairobi Hospital, not really a school, but a place that people gather on WhatsApp to discuss COVID issues. And that matter comes up and nobody has been able to answer. One of the most important or interesting questions which we asked Professor Lule, who has been managing COVID patients in Nairobi Hospital, he told us three things: that Africans in America and in Europe, they're dying much more rapidly than, than even the white people. And then he said, even Africans flying in from Europe, flying in from Dubai with the illness, also die. But the African people, what is African people? The people who are actually the local population are actually not dying at that high rate. Maybe you can mute one of the mics there. Try mute all for a moment. So that question is actually not known. People are not sure as to why that is happening. Nobody can actually explain it. But according to Professor Lule, it is not genetic, because even Africans in Europe, and America, they're dying. So he said maybe there's something environmental, maybe the sun we have here, or the weather, but it's not clear. However, it is clear that we're in the early part of the curve. The curve can still rise. So even if we open up, we have to make sure that we still have social distancing, we still have to use masks, we still have to wash, because that is the safest thing. And one of the warnings is Tanzania. Right now in Tanzania, the government is no longer announcing the figures. And according to the US government and other sources, they say many, many more people are dying in Tanzania because they didn't do the social distancing, washing of hands, the wearing of masks. So we have to do that. At the same time, we must recognize COVID's effects are worst in the economy. In America, they have lost 80,000 people, but they have lost 40 million jobs. So the economic effects of COVID cannot be ignored, because if you are at the end, you have no money, you have no food, you'll still end up sick. So we have to find a way of working without getting sicker. So, in fact, today, WHO, even yesterday, they said COVID-19 coronavirus is not going to go anywhere. It will be here for the next 2 to 3 years or maybe longer. It may become endemic. And therefore, they're saying people will have to be able to live with it. And therefore, you can't hug nobody, you can't shake nobody's hand, maybe for the rest of your life, for all you know. So I think we have to find a way of opening up our economies, yet maintaining those rules that we've.
Thank you very much. Thank you very much, Dr. Mbira. I think, as Dr. Mbira says, what is really the end game? I have several questions that have been sent in the chat section. I'll start with Dr. Mbira Gikonyo. Dr. Mbira Gikonyo thanks Dr. Mbira for a detailed account of COVID-19, and he asks, is there no lifelong immunity after recovery from COVID as reported in Korea, where there was reinfection, and was this a true reinfection?
Now, nobody knows if there's a lifelong immunity. Nobody knows because nobody has lived, very long since COVID came. COVID is about 4 or 5 months old. In the cases of Korea, nobody is sure whether it was a new infection or whether it was just a virus that was still in those people who was picked up, and whether their previous negative tests were what you call false negatives. So nobody knows, but most people believe there will be a kind of immunity. We don't know how long. It may be 3 months, maybe 1 year, like the flu, flu seasons, or it may be 10 years or maybe for life. We don't know. So we just have to go along with life, and then within the next 3 to 4 to 6 months, we see how it goes.
Thank you very much, Dr. Mbira. The next question is from Dr. We have a question from Haji. Thanks, Dr. Gikonyo, for the presentation. Just a controversy. What will be your comments surrounding myths and misconceptions of COVID-19?
Okay, I don't know which particular myth and misconception is talking about. Concerning the origins, it doesn't really matter where it came from, because once it's with us, we have to deal with it. So that doesn't matter. The biggest issues have to do with stigmatization, where people who have recovered, they go back to society, they are chased away, they are mishandled. The other problem has to do with how the government handles people. What we call, making it into almost a criminal offense to have COVID. In Kenya, if you diagnose a patient with COVID, even you as a doctor, you're in trouble. They want to take you for quarantine. We have been fighting this with the ministry and with the medical board, insisting doctors have to have a pass, because at the end, how are you going to treat patients? You can treat, for example, a child for, say acute tonsillitis, you give them the medication, but not suppose the mother or the father is taken 2 days later with COVID. They'll come for you and say you're one of the contacts. So it's a very unfortunate situation, and it needs to be addressed. And every time the ministry actually announces, oh, we are going to be locking up people, you find even the number of people going to hospital falls. Children are at home with fevers, they don't go to hospital. Adults are at home with diabetes, hypertension, they don't go to hospitals because they don't want to be quarantined. So I think that is a big issue. But whether it was made by the Chinese or the Americans, we don't care, because whatever it came from, we have to deal with it.
Thank you so much, Dr. Ari. The next question is from Dr. David. He asks that, can you elaborate on airborne as a route of COVID-19 transmission other than through droplets and surface contamination?
That's a very, very important question, and it's a very, very big controversial issue. In fact, we took more than several weeks to deal with it in our forum, and we actually are the ones who convinced the government to insist people have to wear masks, and the rest of the world has followed. Europe followed, the Americans followed. Even now, you can't see Trump without a mask, much as Trump himself refuses to wear one. So what we need to understand is when we say something is airborne or is droplet-borne, we are saying the same thing. The only difference is that what is airborne, they're in much, much smaller droplets. But it has been demonstrated through very, very good studies, and I can send even 4 or 5 of them, that there is no question about it. If you go into a room with a COVID patient, the very air has the virus. They've picked it up from the air itself, from the ceiling, from every surface in a room. If you go to an ICU of COVID and you walk in there and you don't have the protective gear, you walk out with that virus. It will be there in your shoes, it will be there in your clothes, it will be there in your skin. So it is airborne. WHO was refusing to admit it for unclear reasons. CDC was refusing, but the way it spreads, you don't need to be a genius to know it is actually airborne. However, in our forum, we had a professor called Professor Chunge, who's a professor of microbiology. And from the very beginning, he told us that even 20 years ago, they used to teach the respiratory viruses are airborne. The moment you talk, there are some very, very minute, tiny droplets, very, very small. Don't go to the ground, which actually are able to float in the air for 3 to 4 to 5 hours. So it is airborne. Understand that, accept that, put on a mask. It's what the world is like now.
Thank you very much, Dr. Gikonyo. The next question is from Daniel Ovamba. He says, thank you very much for the detailed presentation. And his question is, could pre-exposure prophylaxis with remdesivir be of help before high-risk ENT procedures?
It may be, But nobody knows because you have to experiment. You see, even though it is a pandemic and an emergency, one of the things that one of the professors on our panel told us is, even in a pandemic, you have to follow the scientific method. You cannot say this will work if there's no experiment that has been done, documented, published to prove it. So one could try it, but we do not know. Yeah, and therefore the best thing is prevention. Gear up if you're doing an operation on a COVID patient. Say your prayers and hope you don't get it, or if you get it, you don't get sick.
Thank you, sir. Dr. Titus Itsenda asks you, are there any false positive results in swab tests?
No, there are no false positive results in a swab test as long as nobody contaminates it. Because the way it is designed, it's a very, very complex test. They actually take the swab from you, they put it into a reagent, and then they make copies, billions of copies of the virus from you. And then from there, they tested the fluorescence to see, it will show up. It's called real time, reverse transcriptase. So in such a case, there can be no false positive unless the person who was taking it contaminated it at the point they were taking it by coughing or sneezing or mishandling it. If they did that and they were positive, then you can get a positive result. But it's almost unheard of.
Thank you very much, sir. Alan Mukunzi asks you, thank you for the presentation. What is your recommendation regarding examining the airway? Should we, and if so, what are the safety measures, if any, that we as ENT practitioners take?
Now you have to make that decision yourself. Some people say, don't look at the mouth, don't examine it. So at the end, how are you going to treat your patients? You need to see what is wrong. You need to see, is it, a tonsil abscess? Is it a tumor? So you have to be able to examine. If you're going to examine, the mouth, then you have to have a mask. You have to have a visor because it can get into your eyes. You have to take all the possible precautions, and then you have to do it very, very briefly. You don't begin, going up and down in the mouth, you don't want the person coughing at you. So you have to be cautious. But, medicine has always required some degree of courage, in handling it. So, but sometimes you have to decide, you can decide, I'm not going to see anybody with a cough or anybody who requires their mouth to be opened. But then, it'll be a strange practice. But with time, you're going to learn. What we are hoping is we don't learn by somebody dying or somebody becoming very sick. Yeah, but you have to be very cautious. In other words, if you're going to examine it very quickly, very briefly. The other thing they said in China is that one of the most important things is to keep the room you examine the patient in ventilated. If there are any windows, open those windows. If any of the COVID begins to come, onto the surfaces, it can actually get blown out. But if you have a room without any windows, then even if a patient came and coughed there, in the morning, by afternoon, it is still around you. You follow. The patient can walk out, you feel relaxed, you remove your the PPEs, you remove your mask, and you breathe in that air. So you have to be careful.
Thank you very much, Dr. Mbira. From Professor Macharia, it's a compliment. Excellent presentation, Dr. Mbira. You've broken it down to chewable pieces. Thank you, Dr.
Thank you very much indeed, Professor.
From Dr. Lynette Mwangi is a question. Is there any role for immunoglobulin infusions?
Nobody knows, but as we talked about the pathophysiology, the biggest problem is that cytokine storm. When it gets to that level, it doesn't really matter what you actually give. Of course, in Europe and even America, because people are desperate, they're doing all manner of things. They've even taken the, serum from patients who've recovered and trying to give it to those who are sick to see if it makes a difference. But most of these studies are still ongoing. It is very, very early. And we still need us, 3 to 6 months to see the difference it actually makes. So at the moment, almost all the experimental therapies being given are failing. They fail when you do a double-blind parallel study, they fail.
Thank you, sir, for that very good reply. From Ngugi Njuguna, the question is, what is the mortality rate of ear, nose, and throat personnel, seeing that infection rate is 3%?
The mortality rate is very low. As I mentioned already, even with the normal standard COVID patients, what they believe is that the true mortality may be about 0.1%. So you can imagine, even among doctors, it will even be much, much less. But the way I look at it, I'll not worry too much about mortality, because if to you mortality is so important, staying alive is, is everything, which maybe it ought to be. If you don't have to see patients, you could avoid seeing patients, which would maybe mean an end of your medical career. Maybe you can just lecture or do non-clinical work, maybe in research. But the moment you're going to see patients, there's always an element of risk. Even before with HIV, the risks were there, hepatitis, the risks were there, and they will always be there. But the beauty, if there's any beauty to this disease, it's that only 2%. So if you were 100 people here and we got it, only 2 of us would end up in hospital. And only 1 or half of that, 2 would end up dead, if at all. So it's not so bad. But still, you have to think about it, you have to discount it, you have to debate it, and then make up your mind how you're going to go forward. But there are many of us, so slowly we'll see. You see too many people are dying, of course you stop. You see nobody's dying, you go on. But generally, people are optimistic. Africa is a safe place to practice up to now.
Thank you so much, Dr. Gikonyo, for that excellent reply. Dr. Wahome Karanja asks, thank you for the excellent presentation. Can we get your presentation?
Yeah, I can send it to somebody. Yeah,
Or is it patented?
Yeah.
Is it patented?
I'm not patented. I can give you it's knowledge.
Patent pending. Okay. Thank you, sir. Thank you very much.
Yeah.
Anyone else with a question? Maybe you can put your hand up in the chat in the participant section. Dr. I would like to ask you just one question.
Yes.
There is a dysgeusia and anosmia reporting tool, a 17-question questionnaire from the American Academy of Otolaryngology.
Yes.
Where you do an online reporting, worldwide online reporting of any patient who presents with anosmia and dysgeusia as a presenting symptom.
Yes.
Of COVID-19.
Yes.
Are you a participant? Are you aware of that?
No, I'm aware of it, but I'm not a participant. I've been only working 2 hours a day for 3 days a week, so I've not been, all that busy. But yes. The patients I've seen, nobody has anosmia. I always ask them, none has admitted to that. So I thought if I begin seeing a number of patients, I could attempt to do it. But I think it's good to participate in a study, especially one like that, which is really questionnaire based. It's worthwhile, to help to contribute to the knowledge.
Thank you, sir. Just before I take Professor Macharia's question, he has just raised his hand. Maybe if there's a colleague, one of us who has handled a COVID-19 case, maybe as a tracheostomy or maybe as an initial showing the patients the other clinicians what a proper nasopharyngeal swab looks like. Maybe you can put your hand up also so that we hear from you. So I'll just unmute Prof. Prof. Karibu sana.
Thank you, Dr. Ochungo, and thank you, Dr. Gikonyo. I just wanted to make 2 comments. The first comment is, of course, to emphasize Dr. Gikonyo's allusion to the fact that hypoxia is one of the symptoms or signs you can use for screening. And the reason why I think we as ENT surgeons need to take this very seriously. A lot of patients that come to us may have, the common symptoms that patients will present. So you don't know. A patient who comes with sore throat or a cough, does that indicate COVID? But I think from various perspectives, hypoxia is a very important sign. I think while you are triaging, because when patients come to your clinic, they triage, and a pulse oximeter is very fast, and a patient who does not have respiratory disease and has oxygen saturation which are less than 90, right? You now can take a little bit more history, and maybe you should send that patient for a test. That is the first thing. The second thing is the question of false negative tests. And in America, this issue has been raised a lot, and it may have to do also with the way the specimens are taken. And like you heard from the old town in Mombasa, that the swabs are going to the brain. because if the people who are taking the screening go on the floor of the nose and are able to go right to the nasopharynx, then that may explain some of the false positive results we are having. Thank you very much.
Dr. Chungo, we can't hear you.
Oh, thank you very much, Prof, for that insightful comments, the two comments. Our next question is to Lynette Mwangi. From Lynette Mwangi, is it mandatory to nurse the intubated patients in negative pressure rooms?
Here in Africa, we barely have any negative pressure rooms in most places. So it's not very practical, but it's better. Negative pressure means none of those viruses are going to get out of there. But it's more theory in Africa than practical, because there are very few negative pressure rooms in any of the hospitals. So I would say it's not compulsory, but of course, if you have it, it's fantastic. Yeah.
Thank you very much for that very good reply. Dr. Jandu Habakash asks, should we routinely wear an N95 mask in the clinic and wards? And how often should we replace it?
The N95 mask is, of course, the best thing to wear, but not everybody can stand it. In some people, it is too tight. Some people can't breathe properly with it. Some people can't stand it for more than 1 or 2 hours. Some people, even in theater, when they wear it, they're unable to actually operate. But if you're able to wear it, it's fantastic. Generally, in an ideal situation, you should use one a day and get rid of it. But now, because it's so expensive, and now in Kenya it's more than 1,000 bob, people are recycling it, people are cleaning them. So if you can use it and you have it available to you, the better, because then you're being cautious. You're protecting your life, meaning your colleagues' life, meaning your family members' lives. But in the hospitals I've gone around, it's not many people who actually use it. Even during surgical procedures, I've seen people in OBGY, people in general surgery, even ENT surgeons, even myself, who can't stand that thing for very long. If the procedure takes more than an hour, some people have a challenge. But it's the best thing if you can able to use it and if you have it available.
Thank you very much, Dr. Gikonyo. Another question comes, we have 9 minutes to go, so anyone with a question, you can either raise your hand or put it in the Zoom group chat. I have a question from Dr. Barak Ongulo. Comment on the stool shedding and infectivity, and what in your comment are the precautions you should take when visiting a public toilet?
Okay, the first thing you should know is that certainly it is shed in stool and can be found in up to 30% of patients, so that is quite high. What they said in China is that you should avoid public toilets, or if you cannot avoid it, then you make sure you don't go to the toilet immediately somebody else has left. They also said that when the toilet is being flushed, people should close the toilet, the lid of the toilet, so that the viruses are not spread all over. However, there is no evidence of anybody who ever got the COVID disease from the toilet. Maybe you don't ask enough questions, but it's a new area. In Europe and other places, one of the ways that they try and check the spread of the virus is to check through sewage, to try and detect a viral in sewage. If it's higher, then they assume it's high in the population. But generally, avoid public toilets, and certainly avoid if somebody else has just been there, because it's in the air and it's possible maybe to pick it up, but nobody knows how infective it is.
Thank you very much, Dr. We have a raised hand from Dr. Charles Gadiro. Doctor, I will unmute you. You can kindly ask your question. Dr. Charles Gadiro?
Maybe unmute him.
I've unmuted him. Dr. Charles Gadiro? Okay. Let me unmute him again.
He's muted. Do it again. Okay. Yeah, that's okay.
Dr. Gadiro?
Hello?
Yes, Daktari, karibu to the webinar.
Can you hear me?
Yes, sir. Kindly ask your question.
Yes, I was asking, yeah.
Yes.
Maybe if somebody can share his or her experiences, eh?
Yes.
During these times, still I'm coming back to the airway examination.
Yes.
Anybody then experience how he's handling the examination of the larynx, patients with the hoarseness of voice at this point in time? Any experiences?
Somebody else can comment. I've not examined the larynx in terms of hoarseness of voice.
In the clinic as an outpatient?
Yeah, maybe professor or somebody else can comment.
Hello. You know that, you know that one of the reasons that examination of the larynx or generally upper airway endoscopy is discouraged is because of the risk of iorizing the viruses. And the risk is, for example, when you put an endoscope in the nose, a patient is more likely to sneeze. When you put an endoscope in the oropharynx, the patient may cough. So if you have to do that, which is recommended only if it is absolutely necessary, and especially if you are suspecting malignancy, then you need to make sure that you are very well covered with PPEs. And the least that at least you should have is you should have an N95 mask. You should have wear goggles or use a face mask. You should also put on a gown, which you will get rid of immediately after. It should be in a room that is well aerated. In many places, the recommendation has been that if you do that kind of examination in a room, you sanitize the room and you close the room for about 1 hour before you come back. So those are recommendations that you find from people that have done this. I have done in the last maybe 2 days, 2 laryngoscopies, one on a patient with a tracheostomy who had a subglottic restenosis. And that one is not really very difficult, although people really are worried about patients with open tracheostomies, but another patient with a suspected malignancy. Luckily, first is being very gentle when you spray the patient so that you try as much as possible not to elicit a gag reflex where the patient coughs onto you. Thank you.
Thank you very much, Prof, for that very insightful answer. I have a question from Haji. What is the turnaround time for COVID-19 tests? And can someone get the results within 24 hours? How come some get results within 24 hours and others in 7 days' time?
Now, it depends on where you're located, but in Nairobi, 24 hours is possible. Even 3 to 4 hours is possible. The test can be done within 3 hours, but it depends on where you are. If you're in Garissa or you're in, far away from the laboratories, it might take a whole day to travel. Then it might take a whole day for it to be done. But even in Kenya, there have been challenges in terms of reagents, in terms of how many they can handle per day, in terms of swabs. And people who are up country, they complain it takes 3 to 4 days, sometimes a week to get back the results. But this is largely in the ministry, but in private hospitals, certainly by the following day, you can get your results.
Okay, so thank you very much for that very good answer, Dr. I have a comment from Professor Machari in the Zoom group chat. Prof says that you can prolong the life of an N95 mask by wearing a surgical mask on top. Then you can wear it for a couple of days. N95 masks have also been sanitized with hydrogen peroxide or ultraviolet light. And the number of times one can resterilize has not yet been determined, but recommendations are about 3 times. So at least the N95 can actually be reused.
Yeah,
okay. So,
thank you.
So thank you very much. I think we've done the 1.5 hours, which we expected. I would first like to really thank Dr. Mbira Gikonyo. Thank you so much for taking your time to do such extensive research. Thank you for being one of the leading lights in otolaryngology and COVID-19. We are relying on you and our seniors for guidance, and we are really happy to have you right in Kent as an invaluable asset in Kent.
Thank you very much. I really appreciate. I was happy to present to all of you and to see many of you for the first time in a long time. Thank you and God bless.
Thank you very much, sir. So thank you everybody for participating. You have been invaluable in your participations. We've had 71 participants, ENTs, and I hope we have all learned something, gotten very good insights from Daktari and from our contributors. Thank you also MMS and the CME team at Kent for facilitating this CME. Our next CME is next week on Thursday, same time, 7 p.m. to 8:30 p.m. And our speaker will be, our topic will be return to work, ENT considerations in the COVID-19 era. Basically, a guidance to return to practice in otolaryngology, head and neck surgery. Our speaker will be Dr. Mujahid Din. Our panelist will be Dr. Samuel Nyaga, and our moderator will be Dr. Wahome Benson. So remember, you'll get CPD points, 3 CPD points per webinar. So kindly do log in and participate in our series. Thank you very much, and may God bless you. Asanteni sana.
Thank you. Bye.